Hi, uh, this is Hatchery Life, and my name is Matt Perez. I'm here with my partner, Jose Leal, and Bindu Kalesan. And we're going to have a conversation about health and how it may not apply to the things that don't apply to people of color as opposed to uh, people of non-color or something, the white people. Um, and it may be that we go over the half hour that we normally give ourselves. So if you want to stay, if not, we'll have it recorded and it'll be in the list of episodes that
Videos.
we have recorded. Yeah, thank you. So why don't we start, Bindu? Why don't you tell us a little bit about your background and Tury Health and how you got to Tury Health? What's so important
Sure.
about that?
Sure. So my name is Bindu Kalesan. So I'm a clinical epidemiologist by profession, which means, we learn how to do good research studies so that we don't make a lot of errors, right? So designing it, conducting it, analyzing the data, and publishing these results. So that's what I do in a nutshell. So I've done a lot of clinical research studies, including clinical trials. And yeah, and what I found was almost all of the research studies that I did mainly clinical trials, majority were done on white population. We enrolled white population. And also, yeah, thinking about it, clinical trials are very, very, very expensive. So the trial costs being so astronomical, we were always trying to reduce costs, right? So, and traditionally, enrolling people of color who are generally mistrustful of the medical community, and also having some distrust, specifically, Black population for the right reasons, it's very hard to enroll the minority populations. So it's what it did was it skewed our results. Most of the trial results are applicable to white population, which does not get said in a clinical environment. So you go to a doctor. If I go to a doctor, the doctor will prescribe me the medications because the FDA approves the drugs. But that doesn't mean that it is tested in people like me and known to be efficacious. And we also don't know the other part of it, like the side effects. What are the safety aspects of it either? So considering that, I thought, okay, startup world is very, very hard. Having a startup is very, very tough. So first we thought, okay, what I wanted to do mainly was our mission was to reduce health disparities. So where do we start reducing health disparities? Primarily, it's chronic diseases. And what I know to do best is to do clinical trials. So founded a company along with my husband, who's always been my partner in crime for all these things. We put our money together. We pooled our money, took out almost everything and put it into the company. And we're trying to grow the company so that we can do decentralized clinical trials, first of all, by connecting people of color, which means not just Black population, but also other population subgroups. Introduce them to clinical trials and conduct them in a way that it is less expensive. When I say less expensive, most of the trials, like the median, is around $30 million to conduct a clinical trial.
Wow.
Yeah, that's a lot of money. But decentralized clinical trials can reduce that by 1/10 to a 1/10. So that's like, that's substantial, right?
Yes.
Substantial reduction in costs. But at the same time, not all drugs can be studied using decentralized clinical trials too. So there are some some trials treatments that are not amenable for this specific method. but we still can reduce the costs and also get people who are currently non-represented into these clinical trials.
Without getting into any trade secrets or anything, why is it so expensive, and how do you bring it down?
Okay, that's the $1 million question, right? So
It sounds like it's a $30 million question.
Yes,
yeah, it's the $1 million question, really. Or so clinical trials is overall a price insensitive environment. So number one, the most amount of money goes into enrolling patients. So to enroll one patient, the median cost around $6,500.
wow.
Right? And then think about all the R&D which occurs, bench side.
So instead of just calling somebody and saying, "Hey, would you like to be in the?"
Yeah. And the traditional approach is this. So we call them a sponsor, right? So industry sponsor. These are the companies who have a drug and they want to test it. So they're called sponsors. So the sponsors would be reaching out to several sites where they can enroll their patients. So it could be universities, some specific clinical settings. So we would go there and then we'll set the site up for clinical trial. So that's a very, very expensive part.
Okay.
Because they have the patients and then they can monitor this patients. They can reassess these patients. So the sites do substantial amount of work and a lot of money goes into those sites.
Okay.
Right? So there's several parts to a clinical trial, which is very, very confusing and also very, very therefore expensive. But it overall sort of makes sense that it can be expensive. But then what DCT does is it does remote patient monitoring. And then what we will do is we are trying to collaborate with another company where we can collaborate with them for obtaining our patients directly. So instead of being site-centered, we want to be patient-centered, which means take care of the patient directly. So we're not going there with a Band-Aid called clinical trial and saying, yep, you know what? Come on. We're going to do a clinical trial on you. Go. That's it. We don't want to do that because it is part of health. Health is a continuum. Right? So we want to be able to treat them, start clinical trials being truly, truly patient-centric. That we have not really done.
From the ground up instead of the other way around.
Exactly. And that's my favorite word, patient-centric. And I hate the way it's just been used and abused so much that, patient centricity means, this big behemoth of our healthcare system, it is nowhere patient-centric. But how do we make it patient-centric? We can't just make it patient-centric. It's not like, covering yourself up with a blanket.
You mean we can't just put patient-centered on the front of our hospital website and that does it? Is that not the way it works? I thought that was the way it worked.
That's the way it works. But
that's how it is working right now, right?
Or not working.
Yes.
I'd love to thank you for all that. That was interesting, very interesting. But I'd love to take the conversation up a little bit. Like you've described specifics of all of the trials that are happening and so forth. But can you give us sort of a bigger picture of the health system as a whole? Because one of the things that I think what you're describing is just one symptom of the broader system. Obviously a very important one because it is at the beginning of how we get drugs in our system.
So that is a really good question. So when I was really getting, upset more with myself on being just part of the whole setup. So this is something that I did. I went back and looked at the history of our healthcare system. Most importantly, I wanted to understand, how did our health insurance come into being? Okay? So what we have currently as our healthcare insurance systems, they are driving everything. They are on the driver's seat,
Right.
right? And it is what we have right now. The healthcare system is mainly hospitals being paid by health insurance systems,
Right.
by the payers, right? So hospitals and payers. So what you don't hear really, or really see with the basics of this healthcare system, is the doctors and the patient. They're nowhere to be seen, right? So, and these are the two entities that are being used by these two, hospital systems and the payer systems. And they make money on them, right? And as you know, doctors are getting really, really upset with the healthcare system as well. They are made to work in a system which they're really given up on. And they know what they're basically doing is handing out band-aids to their patients. They're not really taking care of their patients' health. They're making sure that they manage them. How many
Yes.
times have we heard managing your sickness, right? You get managed.
So
Yes,
today's topic. Go
that's
ahead,
very
Matt.
true. No, I was going to say that's very true. In my own case, it's obvious that what they're trying to do is manage the whole thing. And my doctor, among others, is very frustrated with that.
Yeah. And it's
Yeah.
mainly for chronic diseases. Chronic disorders can be prevented. Nowadays, people are getting chronic disorders much earlier in life. People are getting heart diseases during their 40s, early 40s.
Yeah.
Why is that? Because a lot of our social determinants have changed. How we live have changed. We don't have preventive medicine, right? We just don't have it. Our preventive medicine is making sure that that's only done by 20% of the population, that they go for their annual checkup. That's not really preventive medicine. It's just a sliver of preventive medicine, right? So that is why 90% of our healthcare dollars, which is about $4.1 trillion in a year, goes into managing chronic diseases, right? So it is very, very important that we really understand the burden of sickness and how much we pay for all this with increasing costs. The costs never come down for this. It's always going to go up, right? And with all that, are we really getting healthy? Absolutely not.
No, you're right.
Yeah, actually, this morning we read an article about how the U.S. life expectancy has actually precipitously fallen
Yes.
from the levels that it was even just a few years ago, compared to the rest of the developed countries.
Yes. Absolutely.
By some dramatic amounts. I mean, I was surprised by this, that we're not only not where everybody else is, but we're getting worse much more rapidly and they've leveled off or increased. So what you're describing really, I think, is it what you decided was today's topic. I mean, you're saying, yeah, let's do that. I mean, it's not, we're not talking about healthcare. We're talking about sick care. That's really what our system currently is.
Yes. And we are happily okay with it. It's just, it is what it is. And we've just lulled ourselves into this comfortable situation where, when we are really, really sick, that's when we march ourselves to the doctor. Until then, we don't do much, right? And we have we have a whole lot of stressors, which are very, very, very different from a generation ago.
Mm-hmm.
And we just had a pandemic. We went right back to work after that. But there's a lot of residual illnesses around. So I got COVID 3 times, and then I got long COVID. So I suffer from this chronic disorder, and it's very hard for me. Daily living is hard. So all of a sudden, I mean, I was a person who never got sick, and I had to change my life fully. Like, it's not at all how things were for me. So even with all that, I'm not ready to face my life in a way that, oh, I'm just going to merely manage my disease, right? I'm just not going to do that. I'm going to get myself healthy. I'm going back to health care. I'm going to care for my health. I'm not just going to be caring for my sick person, right?
Absolutely.
So, and I felt like if I'm going to do that, I've got to really be ready to do that outwardly as well.
I lived in Canada for 25 years. And of course, here in the US, we have this idea of what healthcare looks like in a place like Canada.
Yeah.
And one, I was very lucky to have had great doctors, both my own primary doctor and the program in Toronto that I was covered with. What I had lost when I was there for so long, I lost this sense of dread of going to the doctor.
Huh.
It was no longer something that I kind of like, oh, how much is it going to be? And what, am I covered? Is the insurance going to deny me? All of those things sort of just they just disappeared. They went, sorry. It's not to say that it's a perfect system, but when I came back, the first thing in my head was, oh, I need insurance. Oh, which insurance is going to cover me? So I got on Kaiser, but Kaiser doesn't cover this and it doesn't do that. And I'd have to have a Kaiser doctor. And so it was, for me, really a wake-up call, because obviously this conversation has been happening in the United States, pretty much annually for forever. But for me, it was sort of, I get this. And I get it from this feeling of, it feels different to think of what a doctor is here than what a doctor was there. A doctor here is not only a potential of getting better health, but also a lot of risks associated with it.
Yeah.
Right. And it's like, whoa, I never thought I would feel that having come back to the States.
Yeah.
And so for me, it's, how do we see healthcare differently? It's not about healthcare. It's about the economics of healthcare. That's
Exactly.
how we see healthcare. It's from an economic model, not a healthcare model.
Yeah. So for that, we need to have policies, right? Fundamental changes where we need those changes to be incorporated into and made to feel like, okay, we can access healthcare, right? Other than just the emergency stuff, only if we really, really, really need to. But for that, to be honest, I think we have a really long way to go because of our political systems. And I think there's a lot of interest everywhere to capitalize on the current healthcare system as it is. And part of it, I do think it is, digital health, the revolution which has happened right now during the pandemic has in fact worsened it in its own way. But in some ways, it has made things easier too. But this is what I worry, and I've seen that. So let's say we decide digital health companies are about choosing one little sliver and then, okay, let's try to fix it, right? With technology, right? So considering that using technology to fix that little sliver, because healthcare is such an interconnected beast, there are always ripple effects. Like you do some small changes here, something else happens on the other end. And we don't take that into consideration. And these so-called innovations can actually be hurting other parts.
Could you give us an example of
Yeah,
that?
yeah. So this is what I thought, like, like mental health care companies. I don't want to name anybody, but they're trying to really, there's a demand. People need better mental health care. It's very, very hard to find a very good therapist or a psychiatrist. It's
Yes.
very hard. So these digital health companies came in and improved access.
Okay.
Now we have access. But then that access turned into a lot more people taking more drugs rather than, right? So in that case, is that the really right way to go about it? Right. And we don't really think of it like that until we hit it. Right. So that's why I always think that if somebody comes in to innovate healthcare, you've got to sit down with the people, the doctors, and the patients and find out, okay, what are the current problems that the patients are facing? And what are the ripple effects if we try and, do our technological innovations?
Right.
How will it affect? So I feel a lot of the innovations lack that forward thinking aspect and understand it in a more of a whole health situation. So again, the lack of the true patient centricity, right? So we're trying to say, okay, that part in that person alone, right? So that's not really health. Health is more of a whole being situation.
Right.
So,
But are we ready to do we have the whatever technologies or whatever you want to call it for somebody to measure my health and say you're healthy or you're not healthy or things like that, as opposed to, oh, your liver is a problem, let's take care of your liver. Well, that causes things in your kidneys. It's too bad, we'll take care of your kidneys. And so I understand that ripple effect because it's an interconnected system. But and maybe it's my lack of, my narrow experience in the U.S., but I don't feel like there's a way of saying you're healthy and we're going to take care of your liver and prevent your kidney from getting sick. It's not that kind of a thing. It doesn't work that way.
Well, that's the thing. We think it doesn't work that way.
Okay.
It actually does, right? So the doctors, they know it. They learn that. At the same time, so there are disciplines called as lifestyle medicine. So where I come from, our medicine is called Ayurveda. It's a wellness situation. It's a wellness science, and we spend a whole lot of money on wellness, right? So you'll see, like, Indian people and good health, we make sure that we spend a lot of it, a lot of our time, our energy, and our money on that, right? We don't see that here. And Ayurveda is been it sort of changed its way and they call it the lifestyle medicine. So there's functional medicine, understanding the root cause and understanding the patient from their culture, how people eat, what they eat, where they live, and all of that is important because it's not just the genetics alone that is important, but it is all these social determinants of health
Yes.
around a person that is more important than genetics or, any of the genetic stuff that we hear so much, because the effect size in genetics is so tiny. It helps only very small numbers of people, but it really does not help that much in the sense that if you look at real understanding of the social determinants of health, that can help change a person's health. Like
Absolutely.
so there is a way to do it, but we're lulled into that sense that, oh yes, the body is very interconnected, so it's very hard to not damage the other organs when you're trying to treat one organ.
One of the things that we're doing at Radical and with our hatchery is reimagining how we can work together in a way that isn't imposed on us.
Yes.
Right?
Yes.
And what you've described from the healthcare perspective is healthcare is imposed on us by those two parties, the payer and the hospital systems.
Sickcare.
The Sickcare. Yeah, thank you. The Sickcare. Exactly. And obviously they have interests. They're all owned by investors. And they're all seeking to make profits off of those investments. And that's the primary focus of both of those parties.
Yeah.
Obviously, patients are trying to get healthy. Doctors are trying to serve those patients and make money in the process, obviously. I mean, it is the world we live in. But part of what we're trying to do is both learn from people like yourself and have the conversations around, can we, as human beings, as people, actually recreate the organizations we work in and the systems of organizations that we live in?
Right.
And is this something that you think could happen in the healthcare? Could we reinvent healthcare from the bottom up as people and doctors together, not by trying to fix the current system? As you've just described, you said, well, we need new policies. That's going to be really tough when the interests are not for new policies. The interests are for keeping the system as it is.
Yeah, you are right. So the interests are not aligned, right? They want the status quo so that they keep making money. And I'm not against making money. I like money as much as any other person. But what I'm opposed is just for making money, you jeopardize the lives of people. That I'm opposed. So
Right.
I feel your question is very, very important, right? What can we do considering this is a behemoth? We can't move it. The way we made it is gnarly. It's a gnarly mess. So what can we do about it? And we can. That is where digital health and the current systems can do something about it. But we still need to make sure that we don't make the errors that have already been made by this gnarly mess of system that we have currently.
But they're driven by the same interests.
Yes.
That the regular physical hospitals and stuff like that gets driven. My son suffered from depression for a long time. He's still suffering from depression, but he's now, through telehealth, of all things. First, it was easier to get on the phone, so to speak, and talk to a nurse, and the nurse recommended this other guy and this other woman, and she recommended some therapy for him, and he's doing really well now.
I'm so happy.
One of the first things that come up is, what's your insurance? How do you even pay for this?
Yes. And most of the healthcare, we see that too. My husband was looking up and he's like, the doctors I want to go to, they don't take our insurance. So what do we do? Right. Yeah. And that's the song that I hear for a lot of mental health care problems. Yes. So I feel that there are digital health solutions. Like, for example, as much as people say bad things about Cerebral, they did provide access to mental health care.
Right.
Yes, there was some overprescription prescribing drugs there, yes. But then, that again could be because the company kind of grew very fast, and that happens. But they're going back and redoing it, which is very good. So we're seeing the mistakes that have been made. These were all the mistakes that were made by the original systems, the traditional systems. But let's not, when we are doing our own stuff or new solutions, new innovations, let's keep in mind what went wrong first. I think that's where it is. And you're right that there are the interests, our interests don't align because the interest there is money and ours is our health. So
Right.
in that case, what do? Right? There are people. So I was a person who I'm very pessimistic about things. Like everything is broken. But then I met with people who actually cared, who actually wants to move the needle. But with all this, we're never going to say that, okay, this person is going to be doing something really great and there won't be any trouble. No, because we already have this, how do I say, a big shadow cast over us, right? With the current traditional systems
Right.
that are not working. So either way, it is hard. It's very hard. So that's why I started off with saying that there should be some changes, and we should not really give up on those huge policy changes. It has to be made. But at the same time, digital health has a lot of contributions to make. And I do think it's just started.
Do you see digital health as the way that individuals can actually participate in their health again? If one of our approaches to reorganizing organizations is to think about, well, let's realign the interests. I as a worker in this organization want to both manage this organization, not be managed,
Yes.
which is what we've discussed a minute ago. I want to be a co-manager in this organization, not to be managed by someone else. And second, I don't want to be a participant in an organization that I don't benefit
Yes.
from the success of this organization. So I want to be a co-owner.
Right.
Do you see the potential of creating co-owned and co-managed digital networks of doctors and technologies that bring those doctors together so that we're not waiting for the large institutions to be doing that? That's okay.
Yes.
Sometimes life gets in the way. That's all good. Or our dogs.
So yes, I absolutely see that. And what I see is digital health being a tool in making that happen. So number one, we have to improve health literacy. That is what is lacking for all of us, right? Because there are a lot of unknowns about our own health, right? And when you say we want to co-own and co-manage our health, that's it seems like a big ask, but it's actually a very fundamental thing.
Yes.
Right? And in order to get there, first we have to have the knowledge and the understanding of the things as it is, and also what we can do to reclaim it. So we can reclaim our health by co-owning and co-managing our health, by using digital health as a tool and having the right health literacy.
By creating a health system ourselves.
Exactly.
As part owners of this new digital possibility.
But how do we get away from the insurance company being the intermediary and paying for the service? And I got some experience with this. I worked at at a hospital that was owned by the different doctor groups, the radiologists and cardiologists. They owned the whole thing.
Yeah.
And but eventually they wanted the regular pay to come in the door rather than, a lot of money for this and a little for that and a lot of money for this. They wanted that regular pay to come in.
Yeah.
And that more and more they ceded power to the insurance companies.
Yes. You're 100% true. What you're saying is 100% true. So recently, a couple in the 80s. So the gentleman, he had a heart problem. He was having a hard time breathing. He's in his 80s. Okay, early 80s. Goes to the doctor and says, okay, we need to do an angiogram to see whether there are any sort of narrowing of your coronary vessels.
Right.
He was taken in for the angiogram and they found, we can't put in any stents. You need to have a coronary bypass surgery, which is a big surgery for a man who's in his 80s. Yeah. And they said, we can't, because he could be easily medically managed. And the doctors gave him two different options. One is go in and we just kind of clean up your arteries a little bit, or you get a coronary bypass. These are the two options he's got. He never got the option of we can medically manage it, considering your age.
Uh-huh.
He's also a very, very anxious person. Right.
Okay.
So given all these things, I got really upset and angry with the system first when I heard this. It was like an older gentleman putting them through such misery. And on the other hand, I'm looking at my dad. My dad has stenosis. And the doctor said he definitely has to be revascularized. My dad's like, forget it. It came out like that because he had the health literacy to understand that at my age, I don't need any stent. Quality of life, right? We are always, this is why health literacy is our secret weapon.
But is it also, to your point, because one of the other things we do is we also don't have death literacy.
We don't.
In this country at all, right? Death is a thing that we must prevent at all costs.
Yes.
And so instead of saying death is something that is going to happen, and how do we manage the quality of life till that point? What we do is I had a beautiful friend who was actually a high school teacher of mine who a few years ago died. And she was in her 90s. In the last 5 years of her life, every time I would visit her, she would say, they keep me alive and I don't know why. They want to do this procedure and they want to do that procedure and they keep doing this. Why are they doing this to me? Why don't they let me go? Yeah. And well, it just the thought of it makes me emotional, but she suffered in a hospital bed in an old age home for years because they wouldn't let her die.
Yeah.
She wanted to die, but the system didn't let her.
Yeah.
Yeah, we deny ourselves a dignified sunset.
Yes.
It's a beautiful way to put it. Thank you.
I think it's very important, especially like coming from India. For us, death is it's just another part of life. So we don't like really fight death. It's like, okay, my dad just sat me down and said, you know what? We're going to have a talk. I've lived enough. I've had the best life in the world. I have 3 children I'm very proud of. I have grandchildren I'm very proud of. Don't put me on any life-saving medications, life-saving technology, none of it. I'm ready to go. I'm happy with all of you.
I've done my job.
Yeah.
I've done my job.
And I realized when I look at people in this country, death is seen in fear.
Yes.
There is fear, actual, like mortifying fear around death. And that's why for me, I see that as a dignified sunset. We sunrise, we sunset, right? So it's that beautiful life in between that we have to experience. And if we don't let the sunset happen in a dignified manner for people, I don't know. And that again comes back to health literacy.
Well, and it then comes back to, well, it from a hospital's perspective, an institutional profit center perspective,
Yeah.
not doing those things is not cost effective, or at least revenue and profit effective.
Revenue. Yeah.
Right. And so we're back to the same thing. We're back to the interests are not aligned.
Yes.
So can I ask you a question? And maybe this is an unfair question, and we're already 11 minutes over, which I'm really enjoying this conversation. I forgot to realize that we are 11 minutes over. So thank you, Bindu, for this.
Sure.
But is it possible that patients can be given the opportunity to co-own, co-manage their health by working outside of the current system? There are so many people that are not insured. There are so many doctors that are not happy with the insurance system. Is it possible to bring them together into a new way of organizing where, I'd happily drop my insurance if I knew that I could pay a monthly amount to my doctors, and I would see them hopefully twice a year or whatever the case may be.
Yeah.
And they would take my monthly fee and keep me healthy.
Yes.
Not try to get me when I'm sick, but
Yeah.
keep me healthy.
So
Is that a possibility?
Absolutely. And it's actually happening now. There are options where you can buy in. You can buy healthcare, not sick care. Sick care happens with insurance, whereas healthcare can be a standalone. But I do think that right now, the way the healthcare, when I'm talking about the digital health, where we are paying out of pocket, having sort of a subscription platform, subscription model, we're still doing it exactly like sick care. That is where, again,
Right.
I'm going back to the health literacy aspect of it.
Right.
Everything, at least in my opinion, it hinges on one thing: health literacy. What we actually deserve. We never think about that. Like, nobody asks that couple, what do you want?
Yes.
Right? So the person doesn't matter there. And will that person be able to articulate what they want in a fully informed fashion? Until and unless we get to that, we cannot make any other changes, because we are not advocates for ourselves.
So that's the starting place. That's the point of starting.
Yes, we have to.
Are there movements around that?
I think there are. I think there are people who are trying to heal, reverse diabetes, right? And like I started growing mushrooms, like gourmet mushrooms, doing lion's mane, and I had a lot of mental health issues. Now I got myself out of every medication.
It's wonderful.
Yeah, just mushrooms. I grow them and I eat them.
On your farm?
Yes.
In what state did you say it was?
South Carolina.
South Carolina.
Yeah. And saffron and mushrooms. These are my things. So I source saffron directly from India from one farmer. And yeah, there's enough and more studies. Again, part of health literacy. I did not know saffron had that many benefits. and it's not all sorts of saffron. So health literacy is something, I think it's truly that secret weapon that we can all leverage, because I know, like, I live in Kerala. Kerala is that part of India,
Right.
which is very different from the rest of India. We have 100% literacy, and we are very, very big on health. We do Ayurveda, and almost 60, I think about 80% of all the crops are organic. That's just the way of life. And the way the spices are grown. So I think coming from there for me, this was a culture shock here. Why are we not spending things on health? We're spending things on non-health things, but health was something that we always did. It was normal to, just like buying groceries.
Well, it seems to me that our culture is about outsourcing our health.
Yes, that
Right?
is
We don't worry about our health. It's not a cultural conversation that we have. I mean, we all complain about our diseases and everything else, but we don't talk about our health care as if it's something that we control.
No.
It's outsourced to these organizations that we've described, and we lose our interests in that process, right?
Yes, absolutely. That is
Well,
exactly.
we lose the interest, and we lose the patient centricity that she was talking about.
Exactly.
And in our cases, as Jose has said, we're very interested in not just healthcare, but the whole system. And the whole system is not a healthy system. Let's put it that way.
Yes.
So and we wrote a book about it over here, and the whole thing is about start with people, make everything decentralized and transparent, because that's the other thing is you don't know where money's coming from, where's it going, how much is things are cost and whatever. I don't know that very many people know, but insurance companies normally bill for hospitals bill for $1,000, right? And they get paid $300.
Yes.
Yeah.
Oh,
And that's part of the problem, because there's no reality injected in there. It's just, well, we know we're going to get paid $300, so let's make it 1,000. So it goes back to $300. It's almost like a game you pay, but the thing you get out of the system is you get very steady pay from the insurance companies.
yes.
That's because there's the hospital overall, which used to be owned mostly by doctors, not anymore, but and they depend on that income. Okay, so if we went to a co-owned system of some sort, then the only person to deal with is the patient, the me, and that's what we'd like to get to. So among other things. So
yeah. I think I'm going to be the clock guy this time, because it's we've already hit 48 minutes. What do you say we wrap it up there, Bindu? Thank you so much. It's been a real pleasure.
Same here. It was very nice chatting with both of you. And I hope you get to speak with as many people and make some progress by talking to different people and finding solutions.
Yeah.
We'll probably want to talk to you again.
Yeah.
Absolutely. I'd love
and
to.
this isn't about us doing this. This is about our community doing this. And thank you.
Right.
You're now part of that community. So
Thank you.
Spread the word. Let's get out there and be radical about what needs to happen.
Absolutely. Thank you.
Before we go, next week's show is Landis White, co-founder of CoPlace, an inside-out approach to real estate and social impact. I don't know how those two mix, but we're going to find out. And and looking forward to the episode next week, but really, really excited by the conversation with Bindu this week.
Thank you.
Thank you, Bindu.
Bye.